Yeah, well, thank you everyone again for joining us today. Today we're going to be presenting on community health worker workforce development, methodologies for CHW use in addressing the SDOH in vulnerable populations. This webinar is brought to you by the National Center for Health in Public Housing. And today we have a companion. Today we're going to have a presentation from Dr. Kevin Lombardi, who is our Manager of Health Research Policy and Advocacy at the National Center for Health in Public Housing.
Hi, everyone. Thank you for your time today, your concern, and for your service to your communities. A wide body of evidence has established access to safe, affordable housing as a, oh, I'm sorry. It looks like I have the wrong presentation up today. Give me 1 second.
Oh.
There we go. Welcome, everyone. Thank you. Excuse the upset. This webinar will serve as a companion to our 4-session LC on the SDOH completed last week. My interest in this topic stems from my experiences in patient care as a medical doctor and my research as an epidemiologist. As a nonprofit executive, I've managed a large multilingual CHW force in a post-natural disaster environment and have personally dealt with many of the frustrations and challenges you all have dealt with as you grow and expand your CHW workforce. The direction I've chosen to take is based on my conversations with health centers across this country as they develop and expand their CHW workforce in a rapidly changing healthcare environment. Evidence increasingly supports the use of CHWs in addressing the SDOH. However, how CHWs should be used and organized differs from community to community. The primary dynamic dictating this diversity is the different SDOH environments that define our patients' lives throughout our diverse country. CHWs don't just help patients, they make everyone in the healthcare system's jobs easier and more enjoyable. SDOH burnout is increasingly prevalent, and there is evidence that suggests that better addressing the SDOH via CHW use increases work satisfaction and retention in clinical staff. But how should we address the SDOH in our CHW workforce? In this session, we'll review methodologies and frameworks that describe this. After this, I will defer to our speakers. We have Mr. Rod Otten of the Albion Healthcare Alliance, a person-centered care network in Albion, Michigan, which is at the forefront of innovation of the use of CHWs in rural communities. And Mr. Jason Amirhadji, a neighborhood and community investment specialist with the U.S. Department of Housing and Urban Development. Thank you for your time, your service communities, and I will pass it to Fide as she goes over some details about our demographic.
All right, well, thank you so much, Kevin. And before we continue, this is just a kind reminder to everybody that all participants are muted upon entry. Please make sure that you engage in the chat if you have any questions or any comments that you would like to share with us related to today's topic. Please also raise your hand if you would like your line to be unmuted. This meeting is also being recorded, and the slides and recording will be sent via email to all of you after today's session. All right, and this is just some background information about today's panelists. And also, this is some additional information about the National Center for Health in Public Housing. And NCHPH's mission is to strengthen the capacity of public housing primary care grantees and other health center grantees by providing training and a range of technical assistance. NCHPH is also a project supported by the Health Resources and Services Administration that is also a national training and technical assistance partner. And the information presented today are those of the author only. So this shows some health center information. Here we display data regarding residents of public housing and their enrollment as patients as federally qualified health centers. Perhaps more than any other in this demographic class, residents of public housing rely on FQHCs to obtain their health care. A total of 108 FQHCs serve as public housing primary care centers, covering just over 900,000 patients. And there are 458 FQHCs that are in or immediately accessible to public housing that cover approximately 5.7 million patients. All right, and now I will transition this to Dr. Lombardi.
Hi, everyone. Just a little information on our public housing demographics. These data describe the demographics of residents of public housing. As displayed, the 1.5 million residents demonstrate characteristics that differentiate them from the general U.S. population. For example, residents of public housing are approximately 2 times more likely to identify as African American, 1.5 times more likely to identify as Latinx, 1.5 times more likely to be children, and are disproportionately from households that are female-headed with children. Next slide, please. These slides will be distributed at the end of our session. They were designed to give you things to bring to the table as you work within your institutions to change and evolve in our rapidly changing SDOH and CHW environment. The session content objectives are as follows. We'll be discussing recommended frameworks for the use of CHWs, reviewing opportunities available for the use of CHWs and integration into health center workflow, and present an overview of key cases and promising practices. And then we will be transitioning to our speakers. Thank you. Next slide, please. The WHO conceptual framework sets the foundation of the social determinants of health. The social determinants of health are a byproduct of our understanding of human rights, the policy choices we make, and our desire to have more equitable outcomes. For those of you who are interested in expanding your knowledge of the SDOH on a global scale, I recommend taking a look at this framework. It's a great companion with a morning coffee. Next slide, please. An understanding of the whole person is a prerequisite to effective healthcare delivery. Trauma-informed and empathetic healthcare delivery requires that staff be given the time and support to develop their understanding of their communities and for the dynamics that define those communities. The social determinants of health provides a framework for doing this, and these graphics help to show that visually. The social determinants of health will be the foundation for the remainder of our session. Next, please. Screening for SDOH concerns and referral to CHWs is the cornerstone of SDOH program development and CHW utilization. Integrating screeners into workflow is complex. Institutions should examine their workflow closely to examine the best ways to collect and use this data. This graphic describes our recommended process. This is the use of SDOH in a typical outpatient framework where there's an intake, where the patient is processed, an SDOH screener is done, a consultation with the provider, and then later follow-up engagement and continuity of care. For those of you who have existing screeners or looking to change your screeners, planning the change of the screener is complex, and in the subsequent slides, we'll be going over some of the details of when you should do your screener and how you should change your screener to better adapt to the unique needs in your community. Next, please. And if we take that framework and we look at when SDOH screeners are typically done and when research supports their use, we look at the patient continuum. When the patient is processed at intake, typically by an LPN, nurse, or other professional, the screener and SDOH screener can be performed at the same time. That SDOH screener is very helpful in the examination room. Physicians, nurse practitioners, and other advanced providers are typically very time limited when they see their patients. Having access to an SDOH screener that meets their patient needs and is designed to meet the needs of their community will allow those providers to make referrals quickly and to address the medical concerns that are related to those in a comprehensive fashion. When screeners are done and that information is given to advanced providers or physicians, referrals can then be made to social services. During follow-up engagement, community health workers, social services, and other staff members can perform follow-up screeners and engage the patient in the person-centered model at their facility. Next, please. CHWs can also be an indispensable tool for facilitating networking resources in the exam room. This can be utilized in inpatient workflow as well. For many FQHCs, partnerships with a community hospital in their area is an important way to improve continuity of care and access to resource for their communities. Community hospitals often do not have the framework to facilitate this, and FQHCs can be important partners in advising the use of screeners and involvement in the continuity network. This graphic helps to describe that in detail, and there's publications on the lower left that can help you to look at case studies that can describe that. Next slide, please. When looking at the typical inpatient framework, screeners can be applied in a similar way to in the outpatient framework. CHWs or other staff can perform a standardized SDOH assessment during the admission process or before the admission process that gives those key details. Physicians can make referrals to social services and specialists during the inpatient stay that reflect and support the information from the screener. After the patient is discharged, screeners can be performed again in order to collect additional information and to integrate the patient into the person-centered network and continuity of care network in your community. Next slide, please. Many individuals at health centers throughout the country have asked me how they can improve their screening activities. Many also have trepidations when considering to adjust their screeners. Available screeners such as the Prepare screener are general and are designed for a general community in a general hypothetical place. Many of you live in communities that have unique SDOH concerns and unique barriers to patient care that should be integrated into screeners when appropriate. There's data and research that supports the adjustment of screeners appropriately to meet those needs. I would encourage all of you to take a look at the screener you do use, look at the services you have available, and identify any gaps. Are there questions that could be added to better help patient care and network people to resources? If so, following these case studies can help give you a framework for doing that. When looking at these and other case studies, some key takeaways are supported by the literature, which are worth noting. One, that institutions have a wide breadth to improve on existing tools to meet SDOH needs when appropriate. Two, customizability of tools to local SDOH concern is key to program strength. And three, organization culture is a key component of promoting SDOH policies. Next, please. Some more information for you to take to the table. The Thomas Heckel et al. Supports the adjustment and adaptation of SDOH screeners to meet your specific community needs as well, and notes that screening tools should be adapted to meet capacity to address specific SDOH needs, the availability of resources. What do you have available? Do you have transportation networks available? Do you have lead abatement services available? Are these priorities for your community? If so, consider adding them to your screener and consider using these frameworks to facilitate a process to do that responsibly and to do that appropriately. Next slide, please. Many folks or many health centers use the Prepare screener. Prepare screener is broad, but in many ways not comprehensive. This is because it's designed for a general US community. For those of you who are in communities that have specific SDOH concerns and use the Prepare, consider adding extra questions to the end or in the survey that give more detail. For example, do you have a large number of individuals who live in public housing in your community? If so, consider adding that as a question. Do you have a large number of people in your community live in houses built prior to 1978? If so, consider adding that, because lead poisoning and lead toxicity is a major concern in many communities throughout the country. The link to the resource will bring you straight to the Prepare survey. The Prepare survey is available in multiple languages, and I would encourage those of you who are in multilingual environments to have that available. Next slide, please. Another SDOH screener that's appropriate for adaptation is the WellRx questionnaire. It's a yes or no questionnaire. It's very simple and can easily be integrated into an EHR. Next slide. At the bottom, you'll see a link to the resource where you can find this resource. Next slide. Here I have a link to a case study on how a Nebraska community proactively addressed their social determinants of health needs through the use of the screener and integration into their existing CHW framework. Now let's discuss that framework. Next slide. Now, previously we discussed a framework where screeners were applied and individuals were then networked to services. This case study reviews a framework of intake, goal achievement, follow-up engagement, and navigation, where CHWs work with individuals in a person-centered network to meet their needs and coach them to meet their SDOH needs based on available resources. For those of you who have person-centered models or are looking to expand your person-centered healthcare models, a look at this resource and utilization of this framework can help you to set guidelines for your CHWs that are easy to follow and enjoyable for both the patient and the worker. Data management is an important aspect of SDOH program integration and CHW use. Data is only as good as how we collect it and what we use it for. Often, communities will adapt the race and ethnicity questions to adapt to local needs. While this is appropriate in many circumstances, making sure that you stay consistent with these core US Census categories will allow you to be able to share data. Often, communities are unable to engage in data sharing arrangements because their race and ethnicity data is collected in a different fashion than other institutions. Next slide, please. SDOH burnout is a major factor that impacts physician and clinician burnout throughout the country. Data has consistently shown that better support of SDOH policies and SDOH screeners and CHW use in institutions helps to decrease burnout, increase retention, and increase employee satisfaction across the board. When going to the table with your institution to discuss these, consider taking this publication with you. Next slide, please. And some more data to support that as well. Next slide. There's an incredibly complex environment dictating the reimbursement of services by CHWs. What we're seeing across the country, though, is that state governments are taking steps to make CHWs reimbursable in certain circumstances. Here's a look at some of the states that allowed Medicaid payment for services provided by community health workers. Next slide. And here's some detail on some of the new states that have done this as well. Many states, including Michigan, will be starting this in 2023. My recommendation is to take a look at this Kaiser Foundation report as it details the specific situations where CHWs can be reimbursable in your state. Next, please. And for those of you from Michigan, some details and a link to the upcoming Michigan law and what you can expect. The link will bring you to the Michigan Department of Public Health and their recommendations going forward. And now I will divert to our first speaker, Mr. Rod Otten. Mr. Otten, thank you for your time. And if you don't mind briefly introducing yourself and taking your material.
Thank you, Dr. Lombardi. I appreciate the opportunity to talk with our group here today and tell our story here in Albion in terms of how we continue to utilize CHW services in the community to support residents. And my background is in healthcare, and use of social determinants of health has been a regular part of the work that we've been doing. And we've tried to integrate that into the work we're now doing with CHWs in Albion. If you could go to the next slide, please. Just to share with you very briefly about Albion. Albion is in Southwest Michigan, a population of just over 7,500 residents, fairly diverse. About 33% of the population is African American, 6% Hispanic, and it is, again, in the county of Calhoun, where the largest city is Battle Creek at about 55,000 people. So lots of rural parts of Calhoun County, and Albion is the third largest community in Albion. in terms of our program, the Albion Healthcare Alliance, it actually started in 2002 and has an interesting story in that it happened because in 2002, the hospital that was in Albion and had been there for a long time closed. And after it closed, the community came together saying that we have to have some entity in the community that will advocate for community members as it relates to healthcare services and making sure that from an access perspective, Albion residents have access to important healthcare programs and services. Albion's situated physically between Battle Creek and next county over Jackson. Both towns are between 15 and 20 miles away. And it can be very challenging for those who have transportation challenges, et cetera. So we started in 2002, and at that time, we also purchased a building in Albion that was intended for healthcare services. So the hospital closes. We at that time brought in for the county, the Federal Qualified Health Center was located in Battle Creek. They developed a second site on the east side of Calhoun County in our building, which we call the Cram Building. And so located in the building, we had the FQHC plus some additional services besides that, including primary care services. Over time, tenants in the building have changed and evolved, but what hasn't is ensuring that our role in the community as far as making sure that needed services continue to be in the community. We've done surveys on a couple of different occasions in the community to determine what unmet needs continue to exist. From the results of that, we've been able to develop relationships with local providers in the county. And so in our building, we have audiology services provided through one of the health system satellites. We've got eye care services through another provider in another community adjacent. We have also recently in the last year, the health department in the county set up their second site into our building as well. So we have, in addition to the FQHC dental services in our building, we have the health department, these other services, including eye care, audiology, and primary care. Also, we have two community health workers that have offices in the building. So with that in mind, we really have tried to, over time, provide as many services within the building as possible, kind of trying to make it as much as possible a one-stop shop, having the health department, the FQHC, our services there in the building. And that's kind of part of our journey, is really trying to make sure as much as possible we can integrate this type of care for residents in the community and make it as easy as possible. Next slide, please. With that, though, our focus is, Albion is a smaller community. We're the only program of its kind in the community. And we really, in addition to addressing social determinants of health, we really, one of our other main focuses is we are a convener. When a problem in the community is identified that has a healthcare component to it, oftentimes we're convening groups together to problem solve, to come up with solutions to address those problems. So our program is very collaboratively based. Most everything we do is based on collaborations, coordination, and good communication with other providers serving residents in the community. Now I just want to share some of the key initiatives that we're working with. If you could go to the next slide, please. So these are the ones we're going to cover very quickly here in terms of what our community health workers at the Albion Healthcare Alliance are involved with. And you can see everything from traditional services like information referral, involvement in community events, chronic disease, et cetera. So if we go to the next slide, we're going to go into some detail with each of these initiatives. On the information and referral side, as I mentioned, we've got the building. Our community health workers have offices, but they're only in the offices half of the week in terms of providing in-office support. So residents will come in and see them there, et cetera. In the building, one of the things that and it kind of goes along with what Dr. Lombardi was sharing in terms of the screening tools, we're working with the FQHC now. When they have a patient who has social determinant of health needs, they fill out the form. The form is then hand delivered to one of our community health workers, and our community health workers then follows up with their patient with those types of needs. I just had a meeting this past week with the deputy director for the health department, and we're in the process of doing the same thing with the health department now. Again, using the shared screening tool to be able to screen residents as they come in, and then bring them over to our community health workers to be able to have them follow up with them. While we're doing that, we're also talking with the other providers in the building and trying to coordinate all the providers doing the same thing as far as screening for social determinants of health, and then referring on to our community health workers to do the work. Additionally, we take lots of calls over the phone as well. One way we do that, we developed a couple of years ago, we developed a partnership with our local 211. It's called Griffin Place. And we actually take calls 2 days a week for 211, but only specific to our county. The Griffin Place covers 8 different counties, but we told them, listen, we'll take calls for Calhoun County, because obviously that includes Albion. And so it gives us the ability to support Albion residents through 211, but it also does 2 other things. One, it allows us access to 211 software, so that we have the ability to have 211 resources on our computer and be able to utilize those and all of the information and referral services that we do. And then secondly, and Dr. Lombardi referenced the importance of data, we also on a monthly basis, we get a data report from 211, not only on the total number of calls in Calhoun County and the total number of calls in Albion, but what the nature of the calls were, so that from a planning perspective and our ability to react to the data in front of us, we have the ability to know what trends are going on in Albion, in our county, whether they be related to housing, food insecurity, et cetera. It gives us data to work with on a month-to-month basis, and we track that data very closely. Next slide, please. So we're very engaged, being in a smaller community. We're very engaged in a number of community events. Our community health workers actually lead. We organized the first 2, the annual Health and Safety Expo and the annual Healthy Babies Day. Our CHWs organize both of those events are by committee, and so we involve a number of other organizations in the community planning these events. But our community health workers actually lead and facilitate the planning for those events each year. Just past week, we just had our Health and Safety Expo, and we were able to serve over 100 families in Albion with that program. We're also involved, we lead a health table at our local Juneteenth event each year, which we did last week. And then we have some other events that we, again, try to have our community health workers involved, engaged with, to have resources available to residents participating. Next slide, please. So we're very involved. The Albion Healthcare Alliance leads a collaborative group in the county or in the city. We call it the Albion Chronic Disease Work Group. It consists of about 15 organizations, healthcare organizations in the county, as well as 8 different community members who participate in the work that we're doing. We take the data that drives the work that we're doing comes from a number of sources, including our community health needs assessment, from our health system community health needs assessment, and the data that comes from that's specific to Albion. And we use some other data sources to help guide some of the decisions that we make. But the chronic disease work group, as you can see here, we have divided it into 2 different areas based on prevalence of chronic disease. In our county, we know that Albion has the highest percentage of diabetes, sedentary lifestyle, and obesity as far as the numbers go in the county. So we decided to focus on those 3 areas from a chronic disease perspective and do some of the work engaging in that. One of our community health workers has been very involved in helping to set this up, and in fact facilitated one of the work subgroups as we began the work. And so we had her very involved and still have her very involved in the chronic disease work group as far as not only participating, but helping to provide some of the evidence-based practices that we're using, et cetera. But one of the other things that we did was as a part of this process of identifying the chronic disease program, we did some asset mapping. So we worked with Albion College, which is in our community. We worked with a couple of the students there, and we asset mapped neighborhoods in our community. So we have 4 different census tracts in Albion. We know that 2 of the census tracts is where the majority of low-income residents live. And so that's our targeted population, is what we're working and targeting those 2 census tracts in the work that we're doing with our chronic disease work group. So when we first started the work group, we developed our core values for the work group. This continues to drive and keep us focused in terms of the work we're doing around chronic disease. First off, everything we do has to be community driven. We have content experts in the work group, but it has to be the community members that are really driving the work that we're doing, because these community members live in the neighborhoods that we're focused in and really have the ability to help drive the work that we're doing, both through getting the word out in their neighborhoods as far as the activities and the programs that we're doing, talking with neighbors, really getting them engaged in terms of the work we're doing. So one of our most important values is it's got to be the work that we're doing has to be community driven and having the lead go there. Secondly, as I mentioned, the work we're doing is very neighborhood based on data, knowing exactly where low-income residents are living and focusing our support there. Third, using evidence-based programs. So both of our sub-work groups in the chronic diseases that I mentioned have identified evidence-based programs that they're using, and so we are focused on that. Fourth, data. We had to make sure that everything we do is driven by the data that tells us not only the story of our community, but also tells us what are the important trends that we need to focus on as it relates to these particular chronic diseases. And then again, finally, using a strengths-based approach. Everything that we do, we want to make sure we're focusing on the strengths of the neighborhoods and community, not on the weaknesses. In part, that's why we did the asset mapping, is really to identify not only assets within the neighborhoods, but the assets of some of the residents living there as well, in terms of things that we can work with. Next slide, please. As it relates to a faith leader forum, during the pandemic, one of the things that we were seeing, not unlike what I'm sure all of you are seeing, was the significant mental health challenges this provided, the pandemic has provided to folks. And we know that low-income folks are more vulnerable to some of these challenges and so on. So in this, we decided to create a collaborative with the local Albion Ministerial Association and create a faith leader forum. Our community health worker one of our community health workers took the lead on this and continues to lead all the planning that goes into this, as well as the collaborative and communication work that goes with the faith leaders in the community. But we collaborate with 3 of the main mental health providers in the county. We have quarterly lunch and learns where we're again presenting helpful information and resources to faith leaders to help them support their congregation members who are facing some of these challenges. So our community health worker, one of them though, is leading this initiative and facilitates all the meetings as we continue to move forward with this particular initiative. Next slide, please. We, from the very beginning, speaking of the pandemic, from the very beginning, we collaborated in the county. We have what's called the Population Health Alliance, which is a collaborative of many healthcare organizations. For the east side of the county, though, the Albion Healthcare Alliance took on the responsibility of creating microclinics to do neighborhood-based clinics to support residents in getting not only the COVID vaccine, but also flu shots and otherwise. But it also provided us an opportunity to have our community health workers available and providing information on site and continues to for some of these clinics. During this, we created what we call community ambassadors. which are volunteers in the community members who we've trained and engaged in supporting the education, ongoing education around vaccines, COVID vaccines, et cetera. And our community health worker historically has supervised this group of volunteers as we work in neighborhoods, prep for upcoming clinics, things like that. So the community health worker has been very involved in not only overseeing volunteers, but really engaged in the work we're doing to make sure that everyone has access to the vaccinations in the community. Next slide, please. I didn't keep track of my time. Am I doing okay? Yeah, okay. Food distribution. One of the biggest things we do as it relates to social determinants of health is we're the largest food distribution entity in Eastern Calhoun County. So we have a program called the Community Table of Albion. We distribute between 450 to 500 boxes of food each month to residents in the community. Our community health workers are very involved. Obviously, this creates a need for lots of volunteers, which one of our community health workers supervises the volunteers. But it also is about communicating with the providers of the food too. So it's really important that we work with South Michigan Food Bank, Community Action. We're working with a number of providers. So our community health workers are very involved in coordinating all the activities to ensure that this food is being distributed. We have 3 distributions a month. And so our community health workers is really involved in coordinating those activities. In addition to that, we have a food pantry. We serve between 80 and 100 residents each month with our food pantry. Our community health workers, again, are available to do SDOH assessments. And what we're trying to do more and more is coordinate folks using the pantry with completion of the SDOH assessment and seeing if there's some additional follow-up we can support residents by through this particular activity. And then finally, we collaborate with Community Action in our county, and we do food commodities 8 times a year in senior housing in Albion, and our community health workers are very engaged and involved in leading that activity and that collaboration with Community Action as it relates to distributing food commodities in senior housing in Albion. Next slide, please. In terms of coalitions, because I mentioned we're very much a collaboration-based organization, we try to, as much as possible, be engaged in a lot of the coalitions happening in the county. They're included here as far as the Calhoun County Homeless Coalition, Health and Wellness Action Team, et cetera. So as you can see, these coalitions are addressing social determinants of health. It's our way of getting our community health workers engaged with other folks focused on social determinants of health in the county and engaged in the work that we're doing as far as collaboration and coordination. Next slide, please. We just recently received a grant. The Albion Health Alliance wrote a grant to our local millage and received a grant to be able to collaborate with 3 other organizations, including the Albion College Area Agency on Aging and a program called Senior Health Partners. And we are creating an intergenerational program that has college students going in the homes of low-income older adults to be able to provide training on how to better access the internet, telehealth, telemedicine, a variety of different things to ensure we know that low-income older adults, many from a vulnerability perspective, suffer from loneliness, isolation, et cetera. So what we're really trying to work with on this is working with our partners to provide in-home support on technology. The grant also covers tablets. So for older adults who don't have a phone, tablet that they can use, et cetera, we're providing tablets and being able to set up the infrastructure for them to be able to do it. Our community health workers are going to be involved in this project because they're going to be actually doing the assessment at the front end with the older adult to identify social determinants of health needs and be able to address them over the long range of the as we're providing service to the older adult. So we've got both the technology piece going, but our community health workers are actually working with the older adults, trying to address their social determinant of health needs. And be working with over time. It's not just a one-time visit, but it's an ongoing relationship with these low-income older adults in being able to address their social determinants of health. So next slide, please. So just in conclusion, we believe in community health workers in our community. They drive what we do from the Albion Health Alliance perspective. Part of a couple other quick things too, as Dr. Lombardi mentioned, Michigan is getting ready to approve reimbursement for community health workers. Up till now, though, how we paid for the community health workers is through the lease that we get from our tenants in our building, but that only partially pays for it. So we're always relying on grants to be able to support the work of the community health workers. So we're excited. We're trying to position ourselves so that we have the ability to take in the reimbursement structure for our community health workers and do even more. But our community health workers continue to address SDOH, collaboration, that is our primary focus. Again, the work they do focuses on facilitation and just working with other providers on behalf of residents in the community. And again, while we have offices in our building, more and more of the work that we're doing is neighborhood based. And the last thing I wanted to mention was what we're in the process of doing now. We work closely with the Albion Housing Authority, which oversees most of the public housing in Albion. And our CHWs already go into public housing now and provide services in their community room. So we'll have an event. We'll invite residents living there down to the community room, help them out with Medicaid applications, food stamps, etc. We schedule that already. What we're in the process of doing, and our Albion Housing Authority is very on board with this, is structuring it so that we can pursue getting a Ross grant, have our community health workers subcontract through the Albion Housing Authority through the Ross grant to be able to provide on-site community health work, community health work to residents living in public housing. So we're just waiting for the NOFO to be issued for this year for the Ross grant and be able to structure this partnership with public housing to be able to have our community health workers go on site regularly with on behalf of the Housing Authority to support the residents living there. Is that my last slide? Oh, yeah, just my contact information there. And that's all I have for now.
Fide, I'll take it from here if you don't mind. Thank you so much, Mr. Otten. Wow, it's impressive to see what you've been able to do at CHWs. And I'd like to transition us to a roundtable discussion. So here we have Mr. Rod Otten, we have Jason Amirhadji from HUD, and we have our colleague, Dr. Jose Leon as well. And we'll be having a roundtable discussion on some of the material we've covered today. For the rest of the session, for our participants, as we have this discussion, I'll be starting by facilitating the conversation. Please raise your hands or put things into the chat. We'd like to encourage all of you to please contribute to the discussion, raise your hand. We'd love to see and hear from you as well. Here's about some of the unique things in your community and the unique things that you're doing to integrate and use CHWs and partnerships throughout your community. Now, I wanted to start with the first question for Mr. Jason Amirhadji. Jason, you're a community investment specialist with housing and urban development. Can you tell me a little bit about what exactly that is and what you do?
Sure, no problem. Can you hear me?
Yes, sir.
Great. Well, I think the transition at the end of the presentation was perfect, talking about the ROSS program. So the ROSS program, which is the Resident Opportunities and Self-Sufficiency Program, is one of our grant programs at HUD that are run out of the Community and Supportive Services Division, which is where I am. So we are sort of the people, we say at HUD. We run the programs that help fund service coordinators, case coaches. And Ross, I think in particular, is a great program because it has different focus areas, one of which is health. So you can base your grant application on a community needs assessment. that, for example, if what your community needs is health or assistance to seniors or disabled folks or connectivity, that can be the focus of your grant. And it's also unique in that it allows for nonprofits and resident associations to apply for the grant funding. So you don't have to be a housing authority or a private or nonprofit housing owner to apply for that grant. You can just be a community partner who wants to host this program. And, I think it's a really great opportunity to bring services to folks through these sort of service coordinator positions, which one could imagine, also functioning as CHW positions. We also have another program called Jobs Plus, and that program is a much bigger investment. It's a multi-million-dollar grant that funds a 4.5-year program where we have embedded in the past community health worker programs. And you might say, well, what does a jobs program have to do with community health workers? Well, we really see it in two different ways. One is CHWs are sort of a gateway onto the ladder for healthcare jobs. And so we see the relationships between healthcare partners and housing as being critical. We also just know that healthcare is a growth field. So thank you so much, Kevin, for putting that link in the chat for the Ross program. And the other thing is we know that health barriers are significant and can be a major challenge for folks who are trying to get into the job market. So, addressing those health barriers can be an essential component to helping people achieve their career goals. So where I'm seated at HUD, we really see our role as helping to facilitate just this kind of great work that was being mentioned around community health workers. And, our hope would be that there would be greater collaboration between the health and housing partners to make that happen.
Now, Jason, in looking at some of our organizations that have representatives here with us today, they have existing CHW workforces and are working to develop those. When you and colleagues these are of course competitive grants, and when you and colleagues are reviewing that, is it helpful for organizations to have strong existing CHW workforces? Does that help set them for success in these applications?
Yeah, so I think, each of our grants is unique in terms of what it asks for. One thing that's consistent across the board is that we really value existing partnerships and collaborations. So some of our programs like Jobs Plus require a 25% match. So for example, if you're going to request $2 million in funding, you need to show that you have 500,000 in-kind services or other sources of funding. So that could be things like a health partnership where the health partner is funding CHWs. So we definitely value it in that sense. We also value it in terms of several of the rating and ranking factors point to, for example, experience serving the community, past performance. So, that's one way in which you could show having previously addressed health needs. It also asks for sort of your approach and how you intend to use the grant funds. And so I think, that's a ready-made opportunity to talk about leveraging CHW programs. But I'll also just say, I think one way to think about this that may even be the most valuable is that we really want to see community engagement when it comes to designing these programs. And that's engagement not just with anchor institutions and partner organizations, but also with the community itself. In fact, really at the forefront of the process, we would hope, is community engagement. And so, CHWs are sort of, I think, a great example of that, right? There are folks who are hired ideally from the community. They are, gathering community voices and representing that, and also encouraging people to be part of the design process for these grant programs and the implementation. So I think it's just a great resource to have. And there's many ways I think that it strengthens potentially an application.
And Jason, for these opportunities, which kind of pop up throughout the year, is grants.gov the best place to go to find these, or is there another resource that's specific to your organization?
Yeah, so grants.gov is the place to go. So that's where we will post every grant opportunity. But another thing you can do, and I'll put a link into the chat here, is you can sign up. We have a program called HUD Strong Families, and that program supports our housing partners, regardless of whether or not they currently have funding. So we share out different grant opportunities, different resources, and it's just a wealth of information from our federal partners, not just about our grant programs, but thinking about the social determinants of health, looking at grant programs from other agencies. So registering for that will ensure that you get our updates. We will send out blasts whenever we have a new grant opportunity available. So one way is you can, of course, wait to get that from us, but the other way is you can sign up for the mailing list or through grants.gov for an alert and be aware of it that way. I will say we're expecting, we already have Jobs Plus out on the street. That's just for housing partners. We expect Ross and the program that I help run, which is the Family Self-Sufficiency Program, or FSS, to go live shortly.
Thank you, Jason. I see we had a question in the chat from Mr. Rafael Martinez about peer support and CHW and how they differ. These are questions I've heard in the past, and I think it might be good to address it here. Mr. Martinez, could you are you able to ask your question to our speakers? Okay, so Ron, I have a question for you about your your strengths-based approach that you mentioned. Oftentimes in public health, the opposite is done. There's a focus on sort of the negative. What brought you to the strengths-based approach, and how has that helped?
I was able to unmute.
Oh, Mr. Martinez, excuse me. Could you please ask our question? First, could you introduce yourself and what institution you're representing today?
Hi, my name is Rafael Martinez. I'm with Circle the City. We provide healthcare for the homeless. We're a federally qualified health center in Arizona, Phoenix, Arizona.
And you had a question about peer support and CHW and how they differ.
Right, because we were, we're wanting to move, we wanted to add more support to our programs, and we're looking at peer support versus community health workers, because we currently have patient navigators that support some of the work. But I was wondering if what the thoughts were out there regarding peer support versus community health workers. Do some people have both peer support and community health workers, or can a person be both a peer support and a community health worker?
So I see you nodding, Rod. Do you have something to add to that?
I don't have a lot of experience with peer support, so I would, we've always engaged the community health work from that way. So I've not done a lot with peer support. So I would love to learn more, though, because it sounds like there's some very positive, potential opportunities using that way as well. I just don't know a lot about peer support.
Well, in my conversation, Mr. Martinez, with health centers, this is
Kevin, may I?
Please, Dr. Jose Leon.
Thank you so much, everyone, and good afternoon. That is a very interesting question, and in my experience, and having conversations with the community health centers, and you are very aware of this, Kevin, there is the concept, the CHW concept has evolved. We started with the promotores or promotoras de salud, and then we went to CHWs. In some places and some health centers, they call them cultural liaisons. And in this particular case, CHWs are part of a health setting, providing education and being part of all the community aspects, and everything that that can help the patients to either access care or to help them with social determinants of health and everything else. And the person the question regarding the peer support is someone who is or who has had an issue similar to the person that he's trying to help. Like if someone has had substance use disorder, and specifically this is more for those related to behavioral health issues. A substance use disorder person can help someone from the community to address some of the issues or some of the problems that this patient is facing, to overcome any of the chronic conditions that the patient is having. There are others like patients who have diabetes, you know, and if you have another patient who has had diabetes and the patient is doing well, this person can help. This person can be a CHW or cannot be a CHW. And what they need is to have the experience and the education to help others.
Okay, that helps. That helps. Thank you.
You're welcome.
And Dr. Leon, in this framework you're discussing, I see kind of two different things. One, as peer support as being a service a CHW can provide if they have that personal experience, but also the CHW as being able to network an individual to, say, a peer support group or another individual. Am I understanding that correctly?
That is correct. That is correct. And we have done some research, and we've been participating in some research, and there was something related to smoking cessation and how former smoker could help a current smoker to stop smoking. You know, but one of the prerequisite was, you know, to be a former smoker. I mean, only a former smoker can really understand all the issues and complications and the difficulties to stop smoking. So that's and it's a really good way to help patients, and is mostly used for any behavioral health issue.
So I think I have a follow-up. I think this isn't just for Dr. Leon, this is for everyone, but I think this speaks in some ways to diversity in the CHW staff and how important this is. Does anyone have any thoughts on that subject? Dr. Leon, if I could direct back to you, do you see diversity in the CHW staff and experiences as being a valuable asset that they bring to the table?
Of course, that is something that we are trying to find every time. I mean, we first we need to know our community. We need to assess, you know, what the needs are. We need to know. I mean, everything that has been said so far, you know, is to make sure that you are addressing the needs of the community, but not only addressing the needs of the community, but knowing the diversity of your community. And based on that, you can help patients based on that diversity. It's my understanding that we have some health centers, and I'm going back to one of our health centers in San Diego. They have a community that is mostly people from Mexico, but they also have people from other parts of the world. And what they are doing is trying to make sure that these people working as CHWs understand the culture and the language of the communities that they are serving. And so if that is the case, the diversity is important and crucial for a health center trying to help their community.
And if I may add one final point on that, I think that's a great subject for us to end on. But what Dr. Leon is saying, it's supported in the research as well. Your CHW staff should reflect the diversity of your community. And what you may find is improving that diversity may lead to better outcomes in your patient population and better work experiences for your staff as well. Thank you all so much for your time today, for your service to your communities, and thank you to our speakers for giving this valuable insight to our constituents and our colleagues. Have a lovely day, and thank you all for your time.
Thank you, everyone.
Thank you all. And before we end the webinar. This is just a reminder to please complete our post-evaluation survey. Your feedback is going to be very appreciated because that way we can, make improvements, see what other needs you may have in your health center. So you can please fill that out. Thank you. And this is our contact information. Again, you can contact Dr. Lombardi at kevin.lombardi@mgt.com or Dr. Jose Leon at jose.leon@mgt.com or me, feed@mgt.com if you have any further questions about today's webinar. Thank you all again and have a wonderful rest of your week.